for the second discussion in thyroid diseases. And you can see this lady uh, came complaining of this anterior neck lump. So as I discussed earlier in evaluation of neck lumps, first thing to see that it is in the anterior triangle, and something need to be done even if you embark on the history is to us to move to us to swallow and observe whether it moves, because if it moves you take a history on thyroid disease. If it doesn't move, you have to consider of other neck lumps. So of course we asked how long, and then it is the anterior triangle lump, and when you asked to swallow, the lump moved, so it was definitely a goiter. And also the person, along with telling, doctor, I have this lump during the last 6 months, she also said that she is losing a lot of weight. So going into further inquiry, of course there was no pain. It has some size in increment, but it was not rapidly enlarging. But of course, on inquiry, she had all the symptoms, a lot of symptoms suggestive of thyrotoxicosis. She said she's losing weight, and also on direct inquiry, she said she sweats a lot, and also finds it very warm than what it used to be. And also, she said she's feels very anxious, and also said that also she has a tremor of the hands. And so clinically, now we know that it's a goiter, and on inspection itself we saw it is more on the left side, so it could be very like to be a left solitary nodule thyrotoxicosis, but we have to examine and further confirm the morphology of the gland, and also confirm that it is thyrotoxicosis by examination, and of course then later with investigations. So palpation of the neck, which we discussed in the last discussion, coming from back, it confirmed that the person has a left-sided nodule and there were no lymph node enlargement. And then the trachea. The trachea was slightly deviated to the right side. And also we could get below, just get below when she swallows, could feel the lower margin. But if you want, you can double confirm with this percussion. And then take the pulse count. She had a pulse rate of 120 beats per minute, and it was a high volume pulse indicating a hyperdynamic circulation, and also had a tremor. Of course, this is a picture of a different person, but of course you can keep a piece of paper and see the tremor more well demonstrated. But of course she had a definite tremor even with normal examination. And then looked for a bruit, and this patient there was no bruit heard. Most of the time bruits are heard in Graves' disease, but always it's better to look for a bruit. And then eye signs. Again, eye signs are mostly seen in Graves' disease, but these are things that we checked, the eye signs, and we know that there are 4 eye signs in thyrotoxicosis. And again, I said it's mostly seen in Graves. One thing is lid retraction and lid lag and exophthalmos, and also ophthalmoplegia, which is more marked on looking upwards and outwards, because the most worstly affected muscles are the superior rectus and the inferior oblique muscles, and also chemosis. So we'll just take one by one and look what these mean. So in a normal person, you just have a look. You go to your mirror and have a look on your eye, or take somebody at home and see. This is how a normal person it sees, that the iris top part is covered by the lower border of the upper lid, or the superior limbus you can't see, and the inferior limbus is just covered by the lower lid, and here you can't see any sclera, and here definitely you can't see any sclera, neither the top part of the iris, and here you can see all the part of the iris. The inferior limbus just seen, but you can't see any sclera totally around. And what does lid retraction mean? Lid retraction is your upper lid. It retracts back, so your superior limbus is now seen. It may even further retract a little more, where you can see the sclera. But if it's only lid leg, your lower part, it's the same. So if you can't see any sclera here, you just see the inferior limbus of the iris. So then it is not exophthalmos. It's very important to see the difference between this lid retraction, what you see here, but there is no exophthalmos here. But look at this. Now exophthalmos, your sclera starts appearing more than in normal person. Now in normal person, inferiorly and superiorly, at the margin of your iris, you can't see the sclera. But in exophthalmos, you start to see sclera, and it starts initially in the inferior part. So this is an early exophthalmos. And also you see that this patient has a lid retraction also, because the upper eyelid has moved up, so you can see the entire iris, but still you are not seeing any sclera. But here there is, so here he has early exophthalmos and also lid retraction. And this one here, the exophthalmos is even marked than here, because you can see the bottom part of sclera, and also on the top part you can see. So when you look at the eye, just see whether it's a normal eye. First see whether it's normal. If it's normal, no problem. But if you see something unusual, just see whether lower part the sclera is seen or not. If it is seen, that means there is exophthalmos. And then look at the upper margin. And here there is lid retraction, but there is no exophthalmos. Here there is lid retraction as well as exophthalmos, and here it is a more advanced stage. So repeatedly see this diagram and try to identify, understand, so you will not make a confusion. So this is normal, this is only lid retraction, and here the two stages of exophthalmos. So this lady who had features of thyrotoxicosis, the symptoms, high pulse rate, tremor, and a solitary nodule, did not have any features of the person I am discussing, did not have any lid retraction or exophthalmos. And it is also important to remember, now with a person with exophthalmos, they have a difficulty of converging. To converge and see, it's difficult. And also when you ask to look upwards, just without rotating the head upwards, you get somebody at home, just get them to look up, then they have to wrinkle the forehead or withdraw the upper eyelid upwards. But in exophthalmos, when you ask to look up, they don't have to do this. They don't have to wrinkle the head or retract the eyelid, because already it is retracted back. So these are additional things that you may see. But of course, just visually you can confirm that it is exophthalmos, but you can do this also and see, ask to move upwards and see that they don't have to wrinkle the forehead or retract the upper eyelid. So these are for the example. So look at this. Now just for yourself, pause the video and think, what is this? So you'll see this is only lid retraction, because the lower part, the sclera is not exposed. This is only lid retraction. What about this? Now this is a exophthalmos, because your lower sclera is seen, and here the upper limbus of the iris is not seen. So there is actually no lid retraction there. But here it's an exophthalmos, and also lid retraction is there. You can see sclera, but also you'll see that this eye it's normal. So it's only a unilateral case. But anyway, so this eye signs, just about this lid retraction and exophthalmos, just look at these slides couple of times and it will get registered to your brain well. And of course, your home person, you have first look at the normal thing, and of course you can just slightly withdraw the eyelid upwards and just see, okay, this is looks like what it looks like, a lid retraction, and you can pull from down and see, okay, this is exophthalmos. Put on both sides, pull and see. This is how look in a advanced case of exophthalmos. And also just to look upwards without rotating the tilting the head up. And also in a case of lid retraction, when you are checking your visual fields or the eye movements, you can also check for the lid lag, which I'll describe in that a little later. And then of course another eye sign that we mentioned, out of the signs that we mentioned, was a chemosis. So that's what you are showing here. In the chemosis early stage, there will be more edema of the eye, and also there will be excessive sweat, this lacrimation, and also later cases you see this reddening. So this is an advanced case of chemosis. So some people call it a watery eye. And then the eye movements are important. The eye movements, as I said, the worst affected is looking outwards and upwards. Then it's difficult to move, for them to move the eye in that region. And also at the same time, you can check for the lid lag. And you see when your hand is coming down, there's a delay for the, do it in a normal person and see how the eyelid also moves down. But of course in the lid lag you see that with the eye moving down, the upper eyelid, there's a delay to follow. So this lady again, none of these physical signs, the eye signs were there. She didn't have any lid retraction, and also there was no exophthalmos, and the eye movements are normal, and there was no chemosis, so she didn't have any eye signs. So just to summarize, so this lady has a left solitary nodule, and she is clinically thyrotoxic, and the trachea was slightly deviated to the left side, and there was no palpable lymph nodes, which usually in a toxic nodule you would expect to see. I'll come to that bit later. So initially we did the TSH, T4 and T3. And when I discuss the solitary euthyroid nodule, I say if the person is clinically euthyroid, that's the TSH value only is enough. Because if you do all, there are more costs for the investigation. But if you suspect thyrotoxicosis, it's important to do the full profile. There's one thing very important to remember. You do, say, supposing some patient you do TSH only and TSH is low, please don't start antithyroids on that patient. Do the T3, T4. Just see whether they are raised, because there is a small subset of patients where TSH is low but still your T3, T4 may be in the normal range. So if you treat them with antithyroids, they can become hypothyroid, and if they have a goiter, it will enlarge in size. So treat if only T3 and T4 are high, just a lower TSH. Don't embark on treatment without checking the T3, T4. And with a lower TSH also to titrate the doses. Generally, you should know your T3, T4 levels. If they're just marginally elevated, you don't have to give a very high dose, because very soon they'll become hypothyroid in that case. So to treat a thyrotoxicosis, do the T3, T4. Don't do only with TSH levels only. And for that, of course, that I'll come a little later in that particular discussion without making a confusion. So remember, do the T3, T4 also, and ultrasound scan confirm that it is a solitary nodule of the left lobe. It is important to know whether it's only a solitary nodule or whether there are other nodules which you are not feeling, because the treatment of a multinodular toxic goiter is different to a treatment of a toxic solitary nodule. And FNAC, why I put in brackets is, a lot of people think it is not necessary to do FNAC because these are hyperfunctioning nodules. The malignant nodules are hypofunctioning. So in a hyperfunctioning nodule, a toxic nodule, it is very unlikely, even it is early it was believed that the malignancy never happens in a toxic solitary nodule, but there are very few cases reported. So therefore there is no harm doing FNAC, but I will not rush in the initial assessment. first, once they are controlled with antithyroids, then I would do. But of course, there are some instances, I mean, in the discussion later, I'll come to these points. So it is not an absolutely necessary investigation. And the radioisotopes can, again, I put in brackets because it is not often used in clinical practice. And also to just to remark about radioisotope scan in the pre-assessment of a thyroid, of a goiter. The earlier it was helpful for the ultrasound scans were available. Now the users in the pre-assessment is actually it has gone down. But this is one instance. Just I think this is probably only one instance I can think of where radioisotopes may have some value. That is in a toxic solitary nodule, because if you do a radioisotope scan, you can confirm that toxicity is only in that nodule and the other part of the glands are normal. This has an importance, especially if you decide on surgical treatment. uh, that again I'll discuss when I come to surgical treatment. And also, if you are doing a radioisotope scan, you have to do before you start the antithyroid drugs. So radioisotope scan, of course, if somebody asks is it useful in a toxic solitary nodule, definitely the answer is yes. So this patient, we sent this, so investigations T3, T4 both were high, mostly T4, ultrasound confirm a toxic solitary nodule, and FNAC we did little later, and isotope scan was not done because there was a waiting time for that, and we had to start on treatment. So these are practical issues sometimes we face. And then how did we treat? There are only two principles to remember in managing thyrotoxicosis with a goiter. First thing is, everybody, irrespective of the type of the goiter, everybody has to undergo medical treatment and make them euthyroid. That is the first principle. And the second principle is you have to think whether any form of ablation of the gland, either surgical ablation or iodine ablation, is required. That is the second question we have to answer. Or that means, can you get a complete cure with medical management only? That is, you treat for some time with antithyroid, will they go into a remission without, even if you stop drugs, they will be in a remission. So if that is possible, you just do your medical management and stop after some time. So what is the answer to this? Now this one has a solitary nodule. Nodular goiters, whether it's solitary nodule or multinodular goiters, maybe a very small multinodule, it may be different, but general principle, nodular goiters, solitary nodule or multinodule goiters, they will need some form of ablation because they are generally autonomous, and once you stop your antithyroid drugs, very likely that they'll get a relapse. So it's very easy to plan the management, that everybody should undergo medical management, and the nodular goiters will require some form of ablation. So remember those two principles. That's all you have to remember. And so this person has a solitary nodule. So we started the first thing is that we have to uh, start them on medical management. So we started on antithyroid therapy. So we started on carbimazole. So now, what are the ways to give carbimazole? One thing is you can do a titration method where you start on some calculated dose depending on your levels, and then after about 6 weeks you do a repeat evaluation, and then you adjust the doses accordingly, because it's very important that you should not over treat and make them hypothyroid. If you make them hypothyroid, one thing is unpleasant, and other reason is that your TSH will rise and your size of the goiter will enlarge, and it can be dangerous in a large goiter pressing on the trachea, especially a multinodular, and more dangerous in a retrosternal extension. They can even go into acute respiratory obstruction. They can even die of that. if it's very severe. So it's very important to remember, don't overtreat. So carbamazole, start on some dose which you think appropriate, but you uh, get the thyroid profile out of 6 weeks. But tell the patient, if you feel that the size of the gland is getting in bigger, or you feel some difficulties, come back soon. So you can repeat the test bit early. So this is one way to titrate the dose and adjust so that smoothly you get them into a euthyroid state. There's another regime that people call as block and replacement therapy. There you give a very high dose of carbamazole. So your synthesis and secretion of the hormones will come down very soon. And you combine, because you're getting very high dose, very likely they might go into hypothyroid state soon. So you give a replacement physiological dose of thyroxine. So this block and replacement regime is, you give a high dose of antithyroid therapy with a physiological dose of thyroxine. So you get a quick control of thyrotoxicosis while they not be will not be pushed into hypo state, because you are giving a physiological dose of thyroxine. Now this block and replacement regime is generally not necessary in most of the cases. You can just manage with one drug with your antithyroid and you give a sensible dose and titrate. But this block and replacement may be useful if you think in a dangerous situation like a huge multinodular, especially with retrosternal extension. You are worried, you start on carbazole with it. Some people, because their hormone levels come drastically down. So if you are worried in that type of case, you can do this block and replacement regime. Okay, and also this patient, we gave her a beta blocker. She was not a asthmatic, so we start on propranolol. So why do you give a beta blocker? Because that is because your carbazole, now it will be acting from day one, but of course you have this secreted hormones in your system. You have your secreted hormone in your system which has a half life, and it will take a while for those to come down, and also the protein bound fraction is there. So it will, even you have started carbazole, patient will have this troubling symptoms of sweating and the tachycardia and also the tremors, because all these, most of the troubling manifestations are due to sympathetic overactivity. Even it's very interesting, even though your race levels uh, of your thyroid hormones, the troubling symptoms are of the sympathetic hyperactivity, because the thyroxine hormones upregulates the sympathetic receptors. The number of sympathetic receptors become more, so your system gets more sensitive to your normal sympathetic hormone levels. So there is hyperactive of the sympathetic system. That is the most troubling symptoms. So you start on propranolol, but it's important to remember that you don't have to continue propranolol beyond about 4 to 6 weeks, because by that time your carbazole has taken over. Your normal secreting hormones have, the already secreted hormones have cleared off, and so after some time you don't have to continue the propranolol. So anyway, we started on this treatment, and then so she came back to the clinic. So initially a clinical assessment, she was very happy because she had gained some weight and the troubling symptoms are not there. No tremor, the pulse rate had come back to 80 beats per minute, and there's no excessive sweating, and she could sleep well. The anxiety had settled down. And then the repeat thyroid function is important, because the symptomatic control may be due to propranolol partly, but the repeat thyroid functions, both T3 T4 had come to the normal range and they were okay. If it's come down too much, you have to increase the doses, so reduce the doses. But if it's still not controlled, you may have to slightly increase. But she has come to optimum level. So now what is the further management? So going back to these two principles of management. So the medical management, now we have got control, and this is a solitary nodule. So the person needs a ablation either by surgery or by iodine therapy. So this patient, now what are we going to do? Now you look at this. It's a bit of a large nodule, and also we said there is a tracheal deviation to the right side. So this type of person, anyway needs surgery because there's a tracheal compression. And also this volume of when the volume is too much, your radioiodine is very unlikely that will be successful. So most of the solitary nodules with toxicity, generally they need surgery, but if it's a small one, you may consider radioiodine. So this patient, further evaluation of the trachea showed confirmed that the trachea is shifted to the right. So the person was booked for surgery. So what is the surgery you are going to do? So the surgery that we have to do is that person has a enlargement of the lymph lobe, and I said later with the FNS that also didn't show any suspicion of any form of malignancy. So here a lobectomy is adequate. So this is why I said in the pre-assessment, if the facilities are there, if you do a radioisotope scan that has a value, because then you're 100% sure that is only this nodule is hyperfunctioning. But practically, when you do a scan, if you see just one solitary nodule, it is very likely that it is the hyperfunctioning one. So therefore, this patient we plan for a left thyroid lobectomy. This terminology varies. I mean, some people call this hemithyroidectomy, and if the isthmuses include, people say you have to say it hemithyroidectomy. It's changing. I mean, at times people favor this word and this one, but anyway, so we did a left lobectomy, or you can call it left hemithyroidectomy. So the preparation is very important. I mean, normal pre-op preparations for any thyroid you should know, but here there's one important thing, that you have to be 100% sure that the patient is euthyroid before surgery, because if the patient even slightly toxic, there's a high risk that the person may go into thyrotoxic crisis, which even has a recorded mortality rate. So you have to be absolutely sure. You have to do your thyroid functions very close to the surgery, couple of days prior, and double confirm that your both T3 T4 are normal, and you don't stop your antithyroid drugs until the day of the surgery. It's also very important. Some people again combine propranolol during the last few days. I don't know how important it is. And also in the past, people used to give lugolcidine, which thought to reduce the vascularity. And lugolcidine mostly used in Graves' disease before surgery. But these are things just to know that what have been used. So so the person was prepared for lobectomy, and all other pre-op investigations needed for thyroid were normal, and T3 T4 2 or 3 days prior they will still be normal. So we continue the carbamazole up to the time of surgery, and she had the left thyroid lobectomy. And then the post-operative care, normal thyroid post-operative care, just learn from your patient. When can they sit up? When can you feed? When can you get discharged? And now after surgery, stop the carbazole, because if you continue, the person will get hypothyroid because it will be acting on the normal. It will continue to act on the normal lobe. So now the person has only one lobe. The toxic is removed, so there's no this stop the carbazole. And also it is not necessary to start thyroxine, because she has a normal lobe and she was anyway a toxic patient. But after about 6 weeks, you can look at the thyroid profile again, and also better to keep them on follow-up at least once a year. Look at the thyroid profile just to see whether how the hormones are going. So this is a summary of a person who presented with a toxic solitary nodule, and symptoms and the physical signs confirmed the thyrotoxicosis, and clinical examination confirmed that it's a solitary nodule. And then they were by investigations of ultrasound and thyroid functions, the diagnosis of a toxic solitary nodule was confirmed. And how it was managed was by initial medical management with carbamazole and propranolol. Then once the thyrotoxics level, the blood levels came to normal, the person underwent a left thyroid, left lobectomy, because the two principles: first you get the medical control, and nodular goiters, they need ablation. So this is a solitary nodule, so needs ablation. And why we decided on surgery was it was a large nodule compressing on the trachea. So the person underwent a left thyroid lobectomy. A person with a toxic solitary nodule, medical management with antithyroids, get the patient euthyroid and undergoes a left thyroid lobectomy. And for who are the people who can be get ablation with radio, so this suppose on with radioiodine ablation. So as I said earlier, if the nodule is not very big, a small toxic solitary nodule, you can uh, do with radioiodine ablation. So a person coming with a toxic solitary nodule, you initially again you start on medical management, and then later, if the nodule is not very big, you can do radioiodine ablation. And also in an elderly patient, because with radioablation you may get at least you be able to get your carbamazole doses down. So if you think the surgery is not very applicable for a patient, then still there is a place. But if the nodule is not very big, then you can do radioablation. But as I said, practically most of the patients come with larger nodules, and majority undergo lobectomy after initial medical therapy. And this about selecting and also preparation and post care about radioiodine ablation in thyrotoxicosis, I will do a separate discussions once I finish all the other toxic goiters, that's the toxic multinodule and the graves. Once I finish the discussions, I'll do one discussion on about the radioiodine ablation in thyrotoxicosis.